Besides doing MSF work, Sophie also has been very involved in HIV/AIDS and worked with a French government AIDS agency called ESTA, and she supervised their programs in over 18 countries. And aside from that, she has a master's degree in international business in France and a master's degree also in political science from Yonsei University in Korea, and she's done a lot of publications and so on. This is just a small snapshot of all that Sophie does, and I just can't say enough, the level of involvement and commitment and knowledge that Sophie has about humanitarian issues, about humanitarian response, about MSF's role. So we're extremely privileged to have her here and spending the weekend with us. And so with that, I'll hand over now. Thanks.
Thanks a lot, Rachel, for this very kind introduction, as usual. And like Judith did this morning, I cannot emphasize enough how delighted we are in MSF to work hand in hand, shoulder to shoulder with UAEM. And like you did this morning, Rachel, I will actually start my speech by a story. As you said, my life started with MSF in the early 90s in Thailand. MSF was providing medical care in Burmese refugee camps along the Thai-Burmese border. And there, malaria was the main cause of morbidity and mortality among the population. It was resistant to most of the available drugs, to the point that young children and pregnant women had become totally untreatable in our programs. The MSF teams, as you imagine, were extremely frustrated with this situation. They documented the resistance. They looked for alternatives without ever finding a solution. Then, in the mid-90s, some patients came to us with a Chinese drug that they had smuggled into Thailand through Burma. And this drug was based on artemisinin derivatives. This family of new drugs was poorly known outside China. In fact, during the Vietnam War, for both the US and the Vietnamese forces, malaria was a real burden, and it was keeping large numbers of soldiers out of combat. So the Vietnamese asked their ally, China, to provide them with better treatments. And the Chinese academics, what they did first was to screen the plants that they use in their traditional medicine. This is how the artemisinin derivatives were rediscovered by them. Meanwhile, on the Western side, Western laboratories, and especially the US military research institutions, identified several new molecules, among them mefloquine and halofentrin. And as you all know, the Vietnam War was over before this new generation of drug had any impact on the treatment of military forces, but the two US drugs were developed, and we in MSF actually used them in our programs for many, many years. And then later on, the parasite, Plasmodium falciparum, rapidly developed resistance against mefloquine and halofentrin. And this is where the story starts for us, and when we have to turn to the Chinese version that was smuggled into Thailand. But with the Chinese drugs, three main difficulties immediately emerged. First of all, these drugs had not been studied according to international scientific standards. Secondly, they were not economically attractive for big pharma to invest in, because malaria was a disease of the poor, and also because the initial products were not patentable by Western pharmaceutical companies under the Chinese law at the time. And thirdly, it's hard to say, but politically and even psychologically, it was really difficult for Western institutions to recognize that Chinese medical institutions had won the medical battle and found an alternative to outdated malaria drugs. So the first step out of this deadlock for us was to carry out clinical trials using alternative treatments. This was absolutely necessary if we were to have a chance at developing an effective treatment for one of the world's most common and deadly disease before it became completely untreatable. And looking at epidemiological data at that time, it was obvious that there was a crucial need for a new treatment for malaria in many other parts of the world and not just on the Thai-Burmese border. So at the end of the 19, and because the situation was rapidly worsening in sub-Saharan Africa, we decided between 1996 and 2004 to enroll patients and to conduct clinical trials. So during that time, we enrolled 12,000 patients in 43 clinical trials in 18 countries where we are working. Our efficacy studies were conducted according to scientific standards and published in peer-reviewed journals, and they were able to provide evidence on the efficacy of most drug regimens containing artesunate. We also supported at that time the founding of the Drugs for Neglected Disease Initiative, DNDI, which was created in 2003, and whose mission was to fast-track the development of drugs for neglected disease. And in addition to assisting in the development of new regimens to treat sleeping sickness, visceral leishmaniasis, and Chagas disease, DNDI actually helped create ASAC and ASMQ, two single-dose combination treatment for malaria that do include artemisinin and that are in widespread use in Africa and Asia today. As you may know, artemisinin-based treatments are now part of the WHO recommended protocols and have become a reference therapeutic option for malaria everywhere in the world. But as we speak today, our teams in Cambodia are seeing the first signs of resistance to this treatment. We are already certain that this resistance will continue to spread, and we can even anticipate which route it will take. But there is no single alternative treatment in sight. So the reason why I shared this story on malaria with you is that, in my view, it is emblematic of a number of challenges that we still face today in our medical interventions. First, the lack of needs-driven innovation and research, especially when patients are poor and neglected. Second, the persistence of numerous barriers, mostly economic, to access. And third, the need to fundamentally change the system in the long run to promote innovation and access. And as Jonathan from Partner in Health recalled us this morning, the fight for access to medicine always originates for a very concrete and practical problem faced by the patients. It's not a moral or intellectual campaign that we embrace simply because we think it's the right cause. And this is why in my talk today, while addressing these three challenges, I would like to focus primarily on TB, vaccines, and hepatitis C, three areas where innovation and access gaps in the response from the global health system are currently causing tremendous suffering among the patients that we serve. So let's start with, let's go back to the main challenges and start with the lack of needs-driven R&D system. Most of the time, our difficulty to treat patients will come from a lack of appropriate treatment, vaccine, or diagnostic tool, and a lack of attention to groups that are particularly vulnerable. We all know the old estimate that less than 10% of research is committed to disease and conditions that account for 90% of the global disease burden. Last year, MSF organized an innovation conference in New York together with DNDI and the School of Mount Sinai. We decided to look at these numbers again to see where we were 10 years after. And the resulting study, which was published in The Lancet just a few weeks ago, shows that despite some progress, between 2000 and 2011, only 3.4% of all drug approvals were indicated for neglected disease. Meanwhile, the global burden of this neglected disease is estimated at 11%. It is worth pointing out that of these products, only 4, that is 1%, were truly new chemical entities, 3 of which were approved for malaria, and that until 2011, no new drug for TB or neglected tropical disease were approved over the decade. And most newly developed therapeutic products were repurposed versions of existing drugs. So our conclusion is simple. The system is not working, and a fatal imbalance remains in R&D for neglected patients. So take now vaccines and TB as an example of this situation. Vaccines have long been part of the services that MSF offers, particularly in countries where vaccine coverage is low. As part of basic healthcare programs in these places, teams provide children with a slate of vaccines currently recommended by the World Health Organization. So we have DTP, diphtheria, tetanus, pertussis, hepatitis B, Haemophilus influenzae type B, BCG against tuberculosis, measles, polio, and increasingly we're also vaccinating against pneumococcal conjugate vaccine. According to WHO estimates, globally in 2012, more than 20 million children did not benefit from this basic vaccination. One big barrier to better coverage is that in rural areas of resource-limited settings, parents have to travel far to get their children vaccinated, simply because in many cases it is not possible to bring the vaccines to them. At present, these vaccines, those vaccines that we use in our programs, have storage and delivery requirements that can be very difficult to uphold in resource-limited settings. Imagine trying to reach children in a remote village in, say, India or Chad or Central African Republic. The roads are bad and prone to flooding during the rainy season. The vaccines themselves need to be kept at a certain temperature between 2 and 8 degrees Celsius, or roughly 35 to 46 degrees Fahrenheit, lest they become ineffective. But there is no electricity along much of the road to keep for a decent cold chain. And most of the vaccines that we use have to be administered with needles by trained health professionals who are, as you know, in short supply in countries lagging in terms of development or affected by years of conflict. MSF teams on the ground must contend with all of these challenges, from the logistics of the cold chain to the provision of trained medical staff. There is a profound need for vaccines that are better adapted to the settings in which they will be used. If they could withstand higher temperature, if they could be delivered through a mist or a patch, or if the course could be completed with fewer doses, it would be far more feasible to get the vaccines and health workers to the most decentralized health facilities closer to where most people live. And rather than sticking, like we do today, with one-size-fits-all approach that is usually based on US and European models, vaccines R&D efforts should be much more global, responding to the needs of all the children and the health system that try to reach them. Moving now to tuberculosis. So here we are, after more than 4 decades of inaction. As we speak, in 2013, 2 new promising drugs for TB are coming to the market. But unfortunately, very little effort has been made by their producers to assess the drug's efficacy in new combination treatments or in sharing clinical safety data that would allow others to do this work. Effective TB treatment, especially for drug-resistant patients, requires a robust combination of different classes of drugs to prevent development of further resistance to individual drugs. So even though the advent of new promising TB drugs is really a milestone for us and for the 30,000 TB patients that MSF treats in a year, these new drugs won't actually do much to curb the drug-resistant TB epidemic until we know how to combine them and what kind of regimen is appropriate for treatment. Furthermore, the producers of these drugs have little incentive to make these new drugs affordable for all those who from South Africa to Uzbekistan are currently dying from drug-resistant TB and who desperately need access to new and better treatment regimens. So exactly as with malaria 20 years ago, Big Pharma lacks any incentive to perform the research necessary to meet patient needs. Companies are incentivized to work in silos to bring individual drugs to market rather than to perform the collaborative research that would be needed to develop and bring new regimens to the market. And what we face is a future where eventually treatment providers like and NGOs will have to step up and conduct their own clinical trials as we had to do in malaria. That is why we need a fundamental change in the way in which medical research and development is conducted. And this is what MSF, UAEM, and many others are trying to enact through the WHO process. So as part of this process for new models and innovation that Judith presented this morning, MSF has submitted 2 proposals for demonstration projects on innovative incentive and funding mechanisms for R&D. One for open source, multiplex, affordable fever diagnostics, and another for a new framework for TB regimen development. And allow me to briefly explain our TB proposal called the 3P project, Push, Pull, Pull. We're proposing the creation of an open collaborative framework for TB drug regimen development based on the sharing of data, the pooling of intellectual property, and the creation of incentives in the form of prizes and grants. Our proposal encourages multiple actors to enter the R&D process in order to accelerate development timelines, improve R&D effectiveness, and provide more equitable access to better medicines. The proposal delinks the cost of research and development from the prices of the end products created, known as the delinkage that you also know. And this proposal embraces open collaborative innovation models. And your help in supporting our efforts to explain the CEW process and the MSF proposals, and as well as other proposals, of course, your help in explaining this initiative to academics, to researchers, to university, and many others would be extremely valuable, because we absolutely need to broaden the discussion beyond the corridors of Geneva. MSF has also launched an online TB manifesto advocating for better treatments, and I was planning to show you a small clip, but it's not going to be possible. But I encourage you all to sign and go on our website and sign for it. So after R&D, which is of course one of the biggest challenge we face, my second point relates to the newer access barriers that we face. We know too well that access to medicine is not just a matter of finding the right drug or adapting tools to the context in which they'll be deployed. It is also about making them accessible and mostly affordable to those who need them most. And the country where MSF intervenes today presents a very different epidemiologic profile than in the past decades. From Pakistan to the Democratic Republic of Congo, and from Syria to Kenya, we no longer have to deal only with a few rare tropical diseases or only with the poorest countries. Many of the most difficult access challenges are going to be in developing countries that are classified as middle-income economies. And apart from having to ensure access to diagnostic and treatment for the usual suspects, the big 3 like HIV, TB, and malaria, as in the US and in Europe, non-communicable disease, or NCDs, such as cancer, hypertension, diabetes, and cardiovascular disease are more and more common and widespread among the population we are serving. It's particularly true for Syria, Lebanon, and Jordan as we speak. So existing alternative for us and for the countries where we work today are limited to treatments and tools that are most of the time outrageously expensive. We're joining very, very late in the game as MSF for NCDs, although we are, of course, treating patients affected with some NCDs. We have not yet fully adapted our emergency setup to these pathologies, nor have we properly documented the state of affairs, which would allow us to engage in a much more aggressive campaign in this regard. This is a work in process, and we will definitely need the help of other actors to move forward. In other areas, however, challenges of access and affordability are very obvious to us. After more than 40 years with no new drugs, the newly FDA-approved TB treatment, bedaquiline, will most likely cost around $900 for a 6-month treatment course in least developed countries and $3,000 for a 6-month course in middle-income countries. That's just for one drug, but several drugs, as I explained earlier, are needed for effective TB treatment. So this means that new treatment combinations will still cost in excess of several $1,000s per patient, even in the poorest countries, as they do today, and potentially much more in countries classified as middle income, of which many have a high burden of TB, such as India, Ukraine, or Uzbekistan. At least 185 million people worldwide have been infected with hepatitis C virus. But access to treatment is and will continue to be also a huge challenge for those patients. The current treatment that is being used, PEG interferon, is very expensive, as you know, and not ideal in terms of medical outcomes. But some very promising new hepatitis C and oral treatments are coming out of the pipeline very soon. The problem is that they are going also to be completely unaffordable for many. Let me give you one example. Sofosbuvir from Gilead is going to receive FDA and European regulatory approval very soon. According to the latest estimate, it could price in the range of $50,000 to $80,000 for a treatment course in wealthy countries, and there is yet no public indication on what Gilead will charge for its use in developing countries. We know that competition, if it was allowed, could be a game changer because the cost of manufacturing has been estimated to be around $200 per treatment, but there is a long way to go to reach that price. Bringing prices of vaccines down is another crucial priority for us. In 2001, the cost to provide a child with basic vaccinations was $1.38. Today, it's $38.80, an increase of more than 2,700%. Given the fact that the number of basic antigens recommended by the WHO has climbed from 6 to 11, the price was certain to raise, and it was not a surprise. But the jump is largely attributable to the high price of new vaccines, particularly those for rotavirus and pneumococcal disease, which together make up more than 70% of the price tag, resulting in a cost structure that is simply not sustainable for many countries. Gavi, the Facility on Vaccine, has committed almost $8 billion to introduce new vaccines and strengthen existing immunization systems in the developing world. And as the largest purchaser of vaccine for poorer countries, the organization can definitely negotiate more favorable terms for countries it covers. But the problem is that once a country's annual per capita income rises above $1,500, that country begins to graduate and move out from under the Gavi umbrella into a terrain where they will be forced to pay incrementally more in the years to follow. So by 2016, for example, some 17 countries will have lost Gavi support, and more countries are starting the graduation process year after year. They will be no longer eligible for reduced prices, and countries like Republic of Congo or Honduras may soon have to choose which of the vaccines they can afford and which ones their younger citizens will have to go without. One step to correct this would be to loosen the stranglehold a handful of pharmaceutical companies have over the vaccine market, allowing greater competition that would drive down costs. Another step, we think, would be for Gavi to use its purchasing power to negotiate better prices and, just as importantly, give organizations like MSF, organizations that are on the ground, ready to put in the effort to reach as many as possible, give these organizations access to vaccines at the price they negotiate for the governments. And let me tell you why it is important for us to be part of this game. These various issues came together in South Sudan, Yida refugee camp, this past year. A huge influx of refugees from Sudan had completely overwhelmed the services on the ground and created a dismal environment in which disease could easily spread. MSF teams built medical facilities. We saw and treated tens of thousands of patients. We provided a wide range of urgently needed services. And we also identified pneumococcal disease as one of the main reasons children were dying in the camp. And so we decided to pursue vaccinating children with the pneumococcal vaccine as well as the pentavalent vaccine. These vaccines were not yet in South Sudan immunization schedule. And so MSF had to purchase them ourselves. But because Gavi does not make its price available to non-governmental organizations and humanitarian actors like MSF, it took 11 months of lengthy negotiations and bureaucratic hurdles for MSF to secure access to the pneumococcal vaccine. Finally, we were able to obtain a limited number of doses directly from one manufacturer, and we began vaccinating children in the camp in July of this year. So this experience points to the fact that a more workable solution is needed to allow humanitarian actors to respond quickly when needs arise. We know it's possible. 2 years ago, for example, the Serum Institute of India, together with partners like PATH, launched this new meningitis vaccine called MenAfriVac, which protects children from a strain of meningitis, the meningitis A, prominent in Africa's so-called meningitis belt. And because this vaccine was developed to serve people and not profit, it is sold at an extremely reasonable price, just 50 cents per dose. And this vaccine is an example of an innovation model implementing delinkage. Even better, its protection lasted longer than the previous one. The previous one would protect the children for 3 years, while this one protects for 10 years. And every 3 years we had to go back. There was a new outbreak and we had to vaccinate again. So basically it was a complete waste of resources to go for this meningitis vaccination campaign. But its widespread rollout in the region already with the new vaccine has led to a significant decrease in the number of meningitis in the meningitis belt. So I think it's fair to acknowledge that there is a fair amount of public investments that is going to vaccine, TB, and hepatitis. But if the research agendas of public institutions and universities could be positively influenced to better respond to the needs of patients, many things could actually change. And we need your voice and your activism in actively calling on governments, governors, and universities to focus research on real public health needs and gaps, and to include access and affordability strategies from the very beginning of the R&D process, with, for example, the implementation of delinkage and the use of a humanitarian and equitable pricing and technology licensing strategies. Let me now raise my third and last point, the need for a new system. The malaria story that I told at the beginning illustrates how history repeats itself over and over again, and most of the time with the same cynicism and equally tragic consequences for the patients. And today, with the emerging resistance to artemisinin, we're back to square one, basically, in malaria. I know that the movie Fire in the Blood will be presented tonight, and in this movie, the film's narrator pointed out the drug company has lost some of the battles for access, but they certainly haven't lost the war. And indeed, we've won a few battles in the fight for access to medicines. We've secured price reductions of first-line ARVs, whose prices have dropped by 99% in the last 10 years. And we've been able to increase the HIV treatment access scale up to nearly 10 million people today. You know how the Doha Declaration in 2001 was a turning point in the fight for access when it placed public health ahead of commercial interests. From 2002 to 2010, official development assistance committed to health more than quadrupled, from $4.4 billion in 2002 to $18.4 billion in 2010, with the US government contributing a third of it. So there's been many victories. We all remember in 2001 the victory by the South African government over 39 drug companies attempting to block legislation that made medicine more affordable for the country. And more recently, the Indian Supreme Court's denial of a patent to Novartis drug Clevec marked the reaffirmation to protect the availability of cheap generic drugs for poor patients and the right that governments have to fight patent evergreening. These were undoubtedly important milestones, but we haven't won the war. We've made tremendous progress in understanding how the current system functions and where it fails, but we haven't fixed it. And as the current system evolves, we are faced with additional emerging challenges and persistent questions. Thank you. So those questions, there are many questions, but for us clearly it's still a mystery how we can align economic interests and public health imperatives, especially for underserved population. As Judith presented this morning, we are closely following the CWG process, which we think could offer some opportunities of reforming this model. We also wonder how we can allow science to work in a truly open, collaborative fashion, serving public health need. How can we avoid that this TB regimen story repeats itself in 10 years for another disease or with another drug? How can we make this new science more affordable? We know how generic competition works to lower prices for HIV drugs, but how can these lessons be applied to other diseases and new technologies, and particularly biological products? I think that Sarah very eloquently explained this morning how it is not just so easy to transpose one model to another. We really need to invent another approach. And we in MSF, we're convinced that UAEM can be instrumental in proposing and enforcing solutions to these problems. No, that's fine.
Oh, okay.
It's open.
Sorry.
Oh, you needed a break, right? And as we've seen actually with UAEM's Davidin campaign and continued commitment to holding universities accountable through the initiative like the report cards and numerous statements of principal sign-ons, we think you're really well equipped to reach out, and better than we are actually, to reach out to researchers, academics, and other stakeholders who are key in this dialogue. You will be the practitioner, you witnessing, diagnosing, treating the patient's plight. You will be the brain that science needs to evolve. You will be, although there aren't many lawyers in this room, you will be the lawyer who can help protect the rights of the patients. And you will be, and you are already, the activist who can resist and refuse the status quo. And I would like to really emphasize this last point like Rachel did this morning, because we're really waiting for you on this front. Thanks to your presence on university campuses, you are absolutely uniquely positioned to demand changes in the approaches of universities for specific compounds. And we at MSF, we rely on your activism. We rely on you to map public and university funding spent on key promising drugs candidates in TB, Hep C, HIV, and vaccines, and we can provide you with all the list of the drugs we're interested in. We rely on you to pressure universities to only sign a license agreement for these drugs when the agreement fully promotes open innovation and access. We also need you to help push universities, researchers, academics to promote open, collaborative models of research and development, maximum transparency of R&D data, innovative way to manage IP, like pooling and delinkage. So it is a fact that we have many challenges ahead of us, and we're ready to share some of the burden. But clearly, I think that if UAEM had existed 25 years ago when MSF faced its first challenges of access, I don't think we we would be having the same conversation today. So you are the present, you are the future of the access to medicine movement, and we hope that you will be instrumental in changing the paradigm toward a needs-based R&D system, a system that will be patient-centered, a system that does not require years before getting better medical products reach patients, a system where physicians don't have to beg for a more effective and less toxic drug, and where we, non-profit organizations, are not forced to invest with the donors' money in our own clinical trial to offset the inertia of the global health community. A system where science can benefit all patients at a just price, and where the priority of saving as many lives as possible takes precedence over profit. And to finish, I would just like to close the loop with this idea of MSF UAEM collaboration. In MSF, people come and go, and some do only one field assignment, and others, like me, are involved with the organization a bit longer. But this is not so important, actually, the time you spend in the organization, because regardless how long we've worked for the organization, our experience stays in us forever, and it does change our vision of humanity. And I think that UAEM and MSF have this passion in common, and that whatever you decide to do in the future, I'm convinced that your involvement, your 2 days involvement in UAEM will always remain a source of inspiration and pride, and that the aspiration to address the patient needs will remain central to our work. So having said that, I want to thank you for inviting me. It's been an honor to be able to speak to you today, and thanks for your attention.